Welcome everyone to today's webinar. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Russ Nassoff is an attorney who has been involved in the fields of health risk consulting and clinician education for over 15 years, concentrating his work in the areas of infection prevention and risk liability minimization for healthcare and medical issues. He has presented hundreds of seminars and webinars to legal, insurance, loss control, healthcare, and risk management groups throughout the United States, Canada, Europe, and Asia, and at such prestigious locations as the Centers for Disease Control and Prevention and the World Health Organization. Mr. Nassoff has been involved as a consulting testifying expert on such diverse events as recent outbreaks of Legionnaire's disease, Middle East respiratory syndrome, fungal meningitis, and Ebola. He was a reviewer on the 2016 Standards of Infusion Nursing and currently serves on the board of directors for the Association for Vascular Access. He has co-authored books and white papers on environmental healthcare issues and holds a patent on a fungal sensing device. Mr. Nassoff received his Juris Doctorate and undergrad degrees from Emory University in Atlanta. Mr. Nassoff, I'll now turn the floor over to you.
Thank you very much. Welcome everyone to the webinar. I'd like to thank Becker's as well as Accelerate Diagnostics for sponsoring this webinar about an issue that I'm very passionate about and which also unexpectedly and quite coincidentally personally has affected me. Next slide. One of the advantages of doing a webinar is that the presenter, as most of you know, can pretty much be lounging in their pajamas. However, I wanted you to see this photo of me taken a short 2 months ago following emergency surgery for a nasal abscess. I will admit I do have better photos of myself. I had developed a nasal pimple, a very common occurrence. Did not think anything of it till I also started to feel sick. I went to several physicians who put me on 3 different antibiotics. All the while my symptoms continued to worsen till I finally developed cellulitis, had a head CT and a nasal culture, and they identified an abscess in my nasal passage. I had emergency surgery, and all the while my ENT physician is remarking that he wished he had the culture results so that he would know exactly which antibiotic to put me on. Ultimately, he did switch my antibiotic, and I had a complete recovery. But I was lucky. Thousands of very sick patients every day in hospitals are dying waiting for their culture results so that an accurate diagnosis and antimicrobial susceptibility can be identified. All the while, they're typically on a broad spectrum antibiotic, which may or may not work, but does contribute to antimicrobial resistance and the incidence of infections such as C. diff and sepsis, which all too often result in dire consequences for the patient. This webinar is going to address the issue of utilizing fast susceptibility technology as an evidence-based standard of care, enhancing your antibiotic stewardship program, improving patient outcomes, reducing costs, risk, and liability. During the presentation, I'm also going to occasionally refer to supporting legal case law to make key points. Next slide. So as was stated at the outset of this presentation, I'm not a clinician. However, I can talk to you about what I believe are 2 of the most important drivers in healthcare today, and that is improving outcomes and reducing costs, both of which coincidentally are goals of the Affordable Care Act and can be achieved through implementation of fast susceptibility technology. These drivers also have tremendous impact on hospital-acquired infections, antibiotic stewardship programs, and an evidence-based standard of care. Next slide. With respect to improving outcomes, we will be discussing the differences between using clinical practice guidelines, or CPGs, and evidence-based medicine, and how electing to follow evidence-based, fast susceptibility technology can improve antibiotic stewardship programs, thereby improving patient outcomes and reducing risk and liability. We will also be talking about cost reduction and how implementation of an antibiotic stewardship program utilizing evidence-based practices such as fast susceptibility technology can reduce penalties under the Affordable Care Act, as well as reduce costs of care and services provided. Next slide. Many times I'm working with healthcare professionals and I realize that they use legal terminology without really understanding the implications of that technology, of that terminology rather. So when we look at things like the standard of care, the standard of care is defined as the caution that a reasonable person in similar circumstances would exercise in providing care. This does not mean that you have to be perfect, but it does mean that you cannot be negligent. And this applies to early adoption of new technology. All too often, I'm afraid that clinicians are afraid of adopting new technology out of a fear of malpractice. But this really is not a risk, provided negligence is not involved. Next slide. When we talk about medical malpractice is defined as negligence committed by a medical professional. And for malpractice to occur, you need a few things. You have to have a duty, which you have to the patient. You need to have a breach of that duty or a failure to exercise care, which is really the area we're going to focus on, is when you do have a breach. Then you need causation or physical harm caused by the conduct to the patient, and you need a damage or an injury. And those are the elements that are needed for medical malpractice. Next slide. Malpractice occurs when a medical professional does not adhere to the standard of care required of them, and their negligence then results in harm to the patient. And there are really only two main issues in this area which are used to determine if malpractice has occurred. So it's relatively simple. We focus on two questions. Was the hospital-acquired condition or infection preventable? And was the hospital-acquired infection properly and/or promptly treated? These are two of the biggest issues for allegations of malpractice, and they are precisely the same issues that fast susceptibility technology is directed at reducing or eliminating. Next slide. When we look at clinical practice guidelines, or CPGs, what we're generally looking at, or what we're generally referring to when citing some standard in literature or in healthcare, is that clinical practice guidelines are a combination of contemporary professional belief and customary practice. A failure to perform in accordance with customary practice can raise an inference of failure to meet the standard of care. However, hiding behind guidelines, unfortunately, does not advance medical practice, particularly when all too often the guidelines are already dated by the time they are issued. As was mentioned at the outset, I was a reviewer on the recent infusion nursing standards of practice. Very soon after we issued those guidelines, there were things in them that were already not valid anymore. In addition to losing validity, all too often the issuing organization can have an undue influence on the content. So adhering to clinical practice guidelines may actually inhibit innovation in healthcare. Next slide. And because of the uniqueness of each patient, no, go back one. Because of the uniqueness of each patient, every patient is like a snowflake. And because of that, customary practice doesn't always equate to good patient care. Next slide. So if we're comparing evidence-based medicine to clinical practice guidelines, what do we look at? Well, evidence-based medicine requires clinicians to keep informed of current best evidence, even before that evidence is regarded as the prevailing custom. And defendants have actually been found liable for medical malpractice for failure to adopt new technologies, even when customary practice did not involve using them. So an interesting example of this is a 1990 legal case of Washington versus Washington Hospital Center. In that case, the plaintiff patient, Ms. Laverne Thompson, went in for an abortion and tubal ligation. And during the procedure, an endotracheal tube was inserted into her esophagus above the stomach, as opposed to into the trachea above the lung. During surgery, her surgeon noticed that her blood was very dark, indicating a lack of oxygen. Well, Ms. Thompson arrested and was left in a vegetative state. Her husband then sued the hospital for failure to have continuous oximetry monitoring, which would have monitored the oxygen content of her blood during the procedure. But at that time, only a very few hospitals in the country were using continuous oximetry monitoring, and only several studies had been published validating the technology. However, the court held that this was an emerging standard of care that should have been followed. So while early adoption of any new technology does of course carry with it some form of malpractice or negligent risk, next slide, the courts have actually been gravitating towards full support of evidence-based medicine by moving to the reasonable standard as opposed to the customary standard, because what is reasonable may not necessarily be customary. And this is true even if the practice or technology was accepted by just a small but reputable subset of the profession with few adherents. And this was demonstrated in the legal case of Helling v. Carey. Miss Helling was a 32-year-old diagnosed with wide-angle glaucoma. She had gone to her physicians complaining of irritation and pain, which she assumed were from contact lenses that she had been wearing. Her physicians, however, did not give her a glaucoma test because they claimed that it wasn't standard practice to give those tests in patients under the age of 40. Miss Helling sued for failure to diagnose her glaucoma, and the court held that it would have been reasonably prudent, based upon Miss Helling's symptoms, to give her the test, despite the fact that this was not standard practice. So in light of these cases, how does this movement towards reasonable prudence, as opposed to what has been customary in the medical profession, tie in with what's going on with antimicrobial stewardship programs today? Next slide. It's well known that overuse of antibiotics is a driving factor in the growth of antibiotic resistance, which resulted in CDC issuing the 2014 recommendations that all acute care hospitals implement antibiotic stewardship programs. In addition, a few years later, the Joint Commission issued a new antibiotic stewardship standard, and maybe most importantly, CMS is currently working on a conditions of participation directive requiring hospitals to have antibiotic stewardship programs to continue their participation in CMS. The purpose of these recommendations is to establish a goal of utilizing narrow spectrum antibiotics as opposed to broad spectrum drugs, which could encourage bacterial resistance, and to continuously ask the questions of, is it still needed? Is the antibiotic tailored to the culture results? And how long do we need to take it for? Why do we need to ask these questions? Well, infections such as C. diff and sepsis, as well as others, can be triggered by the overuse of broad-spectrum antibiotics. So what we need to know is, what have we got? What will it respond to? How long do we need to take it? And we need to know this very, very quickly. Next slide. And why were those new standards needed? Because we were following CPGs, or clinical practice guidelines, which directed us to complete the course or finish the dose, which may now be equivalent to, this is how we've always done it, what I call the most dangerous words in healthcare. Because studies have shown that stopping the course earlier may actually be effective at reducing overuse of antibiotics and decreasing resistance. What is needed is a daily review of prescription necessity, along with a heightened awareness based upon a risk assessment of those most at risk for infections such as C. diff. So complete the course was the customary practice, or the CPG, but may no longer be reasonably prudent based upon the evidence and technology available. The gold standard now is becoming review of antibiotic necessity and dosage on a continuous basis. Next slide. So why are we still following the old model of clinical practice guidelines or finish the course, where nearly 50% of antibiotics prescribed may be inappropriate? Is it lack of knowledge? Is it fear of malpractice? Is it patient pressure? Is it money? Is it all of the above? Next slide. Or is it because to use the evidence-based standard, we need to know precisely what bacteria are at issue, and we need to know this quickly based upon each individual patient? So what we know is that stopping the antibiotic early may not actually encourage resistance, even though all of our mothers told us this. And what we need to do is change the message from complete the course to take exactly as prescribed. But in order to do that, we need to prescribe precisely for the needs of each individual patient. In fact, patients may be advised to stop treatment when they feel better because overuse may increase antibiotic resistance and can actually proliferate infections such as C. diff and sepsis. Next slide. But with only 50% of hospitals having antibiotic stewardship programs that actually help clinicians to prescribe correctly for each patient, it is important for healthcare facilities to keep current with scientific developments and technologies which help reduce antimicrobial resistance through the use of narrow-spectrum antibiotics prescribed specifically for the individual patient. Putting a patient on a broad-spectrum antibiotic for days while awaiting culture results may not only encourage resistance, but can result in life-threatening infections. And are you really providing the best care by putting a patient on a broad-spectrum drug for days when more rapid, accurate results are attainable at little cost in hours? And are you also risking potential liability? Next slide. Remember, when we look at liability, we look at the issue of whether the hospital-acquired infection was preventable and or was it promptly treated. Remember the two main issues for malpractice. Allegations of malpractice can be justified when there is knowledge of the cause of an infection, such as C. diff, coupled with the lack of an effective antibiotic stewardship program. Furthermore, the standard of care is even higher for facilities such as teaching hospitals, since they're supposed to be places where best practices are identified, and they may be held to even a higher standard, such as an emerging standards of care standard. Remember what I said at the outset. The standard of care definition is the caution that a person in similar circumstances, very important that you look at the circumstances and the resources that are available, would use in providing care. So if you're in a facility that has more resources, such as a teaching hospital, you may actually be held to a different standard of care. The following lawsuits are illustrative of what can happen when you fail to have an effective evidence-based antibiotic stewardship program in place. Next slide. One of the highest profile cases was actually a class action lawsuit in Canada, of all places, because we know in Canada they almost never sue for malpractice. This was a case for Clostridium difficile, which resulted in a $9 million plaintiff's verdict because the hospital failed to have an adequate antibiotic stewardship program in place, and the hospital did not clean, disinfect, properly maintain rooms, or have an adequate infection control program. This resulted in 223 patients infected with C. diff, with 91 deaths. Similarly, in 2010, there was a U.S. case entitled Mariner Health versus Robbins, in which the court found for the plaintiff in the amount of $250,000 as a result of the hospital failing to have a documented C. diff control plan, which amounted to a breach of the standard of care when recurrent C. diff infections resulted. Next slide. There are always risk factors to consider when adopting new technology, because the malpractice standards of today are very different from even those, let's say, back in 1980. But this is not because of a change in law. Rather, this is because of advancements in technology. But advancements in technology don't come along in a nice, smooth fashion. They come along in fits, stops, starts, which create a lot of legal ambiguity during those interim periods. But just like with off-label usage, if we don't try, we won't advance. And as long as your usage is based on sound reasoning, such as having peer-reviewed articles or acceptance by that reputable subset of professionals, and is used in the best interest of the patient, you should be protected. And this applies to whether you're implementing the new technology for therapeutic reasons or even for financial reasons. And all of this comes from a case way back in 1932 called the T.J. Hooper, which actually had nothing to do with healthcare, but had everything to do with the importance of keeping current with technology. The T.J. Hooper and the Montrose were two tugboats that were pulling loads of coal from Virginia to New York City. A terrible storm came up and destroyed the coal barges. And the owners of the coal sued for the value of the coal. The tugboat owners claimed, however, what we call in law force majeure, or an act of God, meaning that they couldn't have predicted the storm, in an effort to deny liability. At that same time, however, 4 other tugboats had left Virginia, all pulling barges of coal. But these 4 tugboats had radios, became aware of the storm, and they safely docked in Delaware on their way up to New York. The court ruled in favor of the plaintiff for the loss of the coal and the failure to use available technology, that is, failure to have those radios available. Next slide. And there will always be impediments to implementation of new technology. Some of these will be valid, such as when technology involves new clinical risk to the patient or changes the underlying process of care, or if the clinical trials, let's say, were questionable, or the innovation failed to obtain FDA clearance, or if, let's say, the new technology requires some form of maintenance which cannot be provided or is unavailable, then in fact implementation of new innovation may be impossible. Other factors that can prevent implementation are things like lack of clinician competency, and you also need to consider cost. But I have to warn you about cost. Courts don't look very kindly on using cost as an excuse if hospitals at the same time are spending large amounts of dollars on things like revenue-generating fancy technology, such as MRIs, which are dedicated at attracting new patients and not focused on centered patient technology, which can result in better outcomes. So the added costs really must be a substantial factor to be considered. In addition to that, none of these impediments that I've mentioned are applicable to fast susceptibility technology. And in many cases, manufacturers themselves can also assist with implementation to facilitate early adoption. Next slide. So very often, manufacturers of new innovations in technology will often do audits and assessments to help identify gaps in products and practice so that you can more readily see where improvements are needed. They can undertake the testing, the clinical trials, the labeling, the risk disclosure, the training and competency validation, the maintenance of technology, and even the interface with medical organizations to effectuate change and inaugurate new technologies. Next slide. So to sum up this first portion, how can fast susceptibility technology improve the quality of an antibiotic stewardship program as well as patient outcomes while reducing liability? Well, firstly, it generates faster, more accurate susceptibility results in 7 hours as opposed to 3 days. More appropriate dosing reduces the use of broad-spectrum antibiotics, which encourage resistance of infection. And identification of specific drug and dosage based upon each individual patient needs are really what's needed, and this is what this technology does. And we have the peer-reviewed evidence in addition to this to back this up. Next slide. So Accelerate has nearly 30 peer-reviewed articles and posters from highly regarded healthcare institutions regarding the benefit and use of fast susceptibility technology. demonstrating, for example, at Barnes-Jewish, a reduced mortality for bloodstream infections because patients were placed more rapidly on the appropriate antibiotic therapy, so resulting in 70% of the patients obtaining the correct dosing 40 hours earlier than otherwise would have been the case. At Northwestern, 56% of patients with bloodstream infections were de-escalated more quickly, and 11% escalated earlier as needed based on fast susceptibility diagnoses. And at Geisinger, faster, more accurate results, which helped to rule out complex polymicrobial infections. All of the studies done have confirmed that faster, more precise therapy resulted in reduced mortality, length of stay, and improved outcomes. Next slide. And those peer-reviewed studies are also supported legally by the case law. So if we look at the 2013 case of Montoya versus Barragan, this was a case, another judgment for the plaintiff in a wrongful death action, for the physician failing to prescribe the correct antibiotic because he or she was waiting for culture results, when it should have been clear the patient was already suffering from severe C. diff and sepsis. Had the proper diagnosis been made using fast culture results, the appropriate antibiotic and dosage could have been given and saved the patient's life. Similarly, in a recent case of Gartrell versus UHS in 2017, over a $13 million judgment for the plaintiff due to a delay in antibiotic treatment for sepsis, which resulted in a triple amputation. Next slide. Lastly, in the Plavetsky case, a patient was initially given clindamycin, which we know is a known factor for potential C. diff development, for a vaginal infection that she had. Days later, when the cultures came back, Cipro was added due to the presence of Pseudomonas. The patient started having diarrhea and was then taken off the clindamycin, but the patient continued to have diarrhea, was eventually diagnosed with C. diff, and had a colectomy. Again, had they used fast culture results, the clindamycin would probably not have been necessary in the first place. So the failure to have an evidence-based antibiotic stewardship program can bring about potential liability. So what are the core elements of an evidence-based antibiotic stewardship program? Next slide. So you've got leadership, you've got accountability, you have drug expertise, you have taking some action or intervention, tracking, reporting, education, and training. Next slide. If any of these above 7 elements are lacking, however, the quality and effectiveness of your antibiotic stewardship program is going to be compromised. Next slide. So when we look at these components individually, we look first at leadership. So you must have facility support to improve antibiotic usage. This includes detailed job descriptions and performance reviews, as well as support for education and training. And there's got to be multidisciplinary involvement. So we're going to involve clinicians, infection preventionists, quality improvement, laboratory staff, IT staff, and nurses. And we've got to have financial support. Even though these programs ultimately pay for themselves based upon the data in drug savings and indirect costs, we need to have initial financial support. And you need to have accountability. And with accountability, we need a farm leader and we need a stewardship leader, both of whom should have training in infectious diseases. We also need clinicians because as prescribers, they've got to be supportive of the stewardship program. We need infection preventionists who are going to monitor, track, report data, trends of infections. We need quality improvement folks so we can optimize antibiotic use as a quality measure and improve those all-important patient satisfaction scores. We need lab staff to guide the proper use of tests and the flow of results and can guide therapy by creating and interpreting antibiograms and ensure optimal antibiotic usage. We also need the IT folks to help integrate stewardship protocol into workflow, create things like alerts, facilitate collection and reporting of data. And lastly, but not leastly, we need the nurses who can ensure that cultures are performed prior to starting antibiotics and can initiate discussion around duration of treatment. Next slide. So as I mentioned, it's very important to have clear roles and responsibilities, as the failure to do so can result in messes like this in healthcare, where no one knows who's driving the ship or which direction it's going, and creates real problems with respect to enterprise risk management. And we all know in healthcare that fear of challenge is endemic. There's a fear of not fitting in, there's a fear of individual responsibility, there's a fear of criticism, there's a fear of appearing incompetent, there's a fear of reputation damage. It's what they call in Australia, I've learned, as it's a fear of being the tall poppy or sticking out. And fear of challenge is endemic in healthcare. And unfortunately, fear of challenge is the same thing we talked about when looking to hide behind the clinical practice guidelines. It can lead to stagnation and failure to achieve evidence-based compliance. But working as a collaborative team with clear organization reporting requirements can prevent this disaster in hospital risk management, which can very often look like this. Next slide, please. And here you see what a disaster the typical ERM can look like, with nobody knowing who to report to or what their responsibilities might be. Next slide. So the final four elements of an evidence-based antibiotic stewardship program include drug expertise, taking actions or interventions, tracking and reporting, and training and education. With respect to drug expertise requires you to develop and implement facility-specific treatment recommendations based upon national guidelines and local susceptibilities. So it requires you to implement policies that support optimal antibiotic use, documenting the dose, the duration, the indication, and to make these readily identifiable so that modifications can quickly and accurately be made. Next, we look at actions or interventions to make improvements or changes. This involves things like timeouts, which are a constant reassessment of need, susceptibility, route, dosage, duration, better options, drug duplicity alerts, drug interactions, automatic stop orders. Also includes asking questions like, does this patient have an infection that will respond to these antibiotics? If so, is the patient on the right drug in the right dose with the right route of administration? Or can a more targeted drug be used? Can we de-escalate? And how long should the patient be on the drug? You need to choose the intervention based upon the need and, again, the resources that are available and the applicable competencies. Then we look at tracking and reporting. That includes assessments and audits. Assessments are not the same thing as audits. I find this in healthcare all the time. The two are unfortunately used interchangeably. But an assessment looks at the good, bad, and ugly of what you're currently doing. That will lead you in the direction of potentially finding or doing an audit, which will find the gaps or what the needed improvements are, to evaluate the clinical outcomes of the antibiotic stewardship program and to evaluate the impact of the interventions that you're using. Lastly, training and education, which will include updates on prescribing, resistance, new technology, and most importantly, competency validation. Training and education don't mean that you're competent, so we want to be sure that there is competency validation going on. Next slide. And if you do all this, and you have clear roles and responsibilities and accountability in an evidence-based antibiotic stewardship program, then your enterprise risk management should look like this, with clear lines of reporting and responsibility, a lot better than the mess that was pictured on the earlier slide. Next slide. So to bring this all together and to summarize why using fast susceptibility technology will result in improving patient outcomes, remember that evidence-based medicine requires clinicians to keep informed of current best evidence and adopt new technologies or procedures even before the evidence is regarded as customary. The future of antibiotic usage is rapid diagnosis, tailoring dosage-specific results for the individual patient, So using narrow-spectrum, microbiome-sparing choices and de-escalating as quickly as possible. Antibiotic stewardship programs that are not in compliance with evidence-based practice may encourage antibiotic resistance, resulting in adverse patient outcomes, particularly for infections such as C. diff and sepsis, and may also, now you know, increase liability exposure. You've got to have and comply with those core elements of an evidence-based antibiotic stewardship program, including leadership, accountability, drug expertise, action, tracking, reporting, and education, implemented in a clearly and carefully defined enterprise risk management program. Next slide. Faster antibiotic susceptibility results leads to faster therapy optimization. So its results in less than 7 hours from a positive blood culture, which is 36 hours faster than the typical methodology. And it delivers the minimum inhibitory concentration to the pharmacist to select the right drug in the right dosage at the right duration with the least collateral damage to the patient, thereby meeting the standard of care with a comprehensive antibiotic panel for treating patients with things like bloodstream infections. Next slide. Fast susceptibility technology will also do something that we strive for in healthcare all the time, which is reducing clinical variation across the continuum of care. So we need to move to more uniform and standardized treatment algorithms. We know that in healthcare. If we've got variation, we've got issues. It also generates reports that are formatted to assist clinicians in decision-making and generates treatment that's tailored to the specific needs of each individual patient. It avoids the complexity of molecular test result interpretation and the historical bias that we know is common with antibiograms. And lastly, legally, this is the emerging evidence-based standard of care, which you know you're going to be held to. And lastly, this will have a positive impact on the bottom line, or the money. And so we're now going to talk about, in the last portion of the webinar, the money issue. Next slide. So we're now going to discuss the financial portion of the program with respect to how implementation of fast susceptibility technology improves the bottom line in terms of reduction in penalties and cost of care. With respect to penalties, I created this healthcare wheel of fortune, which details in one slide the impacts of the Affordable Care Act, or whatever we're going to be calling this new act, with respect to healthcare facilities. And it doesn't really matter what we call the new act. Healthcare needs to pay for itself. And it all starts in the upper right-hand corner there with implementation of data-driven, evidence-based technology that meets the standard of care, which then results in improved outcomes, everything I've been talking about. If you improve outcomes, then you reduce readmissions, hospital-acquired conditions under the ACA, and improve value-based purchasing, which then improves morale, reporting quality, and status, which then leads to a decrease in risk and liability and improves the quality of care, patient satisfaction, and safety and efficiency, which generates more profit, more salary, more bonus, a happy C-suite, which then leads to more investment, which can start the cycle all over again in investing in more data-driven, evidence-based technology. Because the ACA is all about improving outcomes and reducing costs. Next slide. So the Affordable Care Act is all about paying for performance and not fee for service. We're going to look very briefly at 4 aspects of the Affordable Care Act: value-based purchasing, readmission reduction, hospital-acquired condition, and inpatient quality of reporting, all of which can translate into great penalties or incentives for your organization, and all of which can be impacted by utilization of fast susceptibility technology. So under value-based purchasing, hospitals pay in a certain amount of money, and then they either get it back, they lose it, or they make a bonus. CMS makes nothing on this program. It's budget neutral for CMS. And your scores are all based on something called a total performance score, which is comprised of improvements, that's how well you did on certain quality measures versus the prior year, and achievements, which is how well you did versus other hospitals. And achievements are weighted heavier than improvements. And you can see the average penalty paid under value-based purchasing in 2015 was over $90,000. Next slide. And when you look at what the total performance score is composed of, you look at 2013, it was primarily based upon clinical process, so the old fee-for-service model. Well, we now know that we're moving towards pay-for-performance. So you see that in 2017, the scores are more heavily based upon quality, safety, patient satisfaction, all of which are going to be negatively impacted if you have high infection rates. Next slide. And you can see very simply from this graph or this illustration that fast susceptibility improves all of those things that we want to improve under value-based purchasing. So patient satisfaction, efficiency, outcomes, and safety. Everything that is weighted highly in your total performance score. Next slide. The next aspect is hospital-acquired conditions. This is where you get a 1% penalty for the lowest 25% of performers for a variety of hospital-acquired conditions. And you see two of them very importantly down there, C. diff and post-op sepsis. Infections are very heavily penalized under the Affordable Care Act. And you can see there the average penalty was almost $600,000 for hospital-acquired conditions. And this also includes bloodstream infections. Next slide. How you're ranked with respect to hospital-acquired conditions is based on two domains. Domain 1, which includes bloodstream infections and sepsis, is rated at 15%. Domain 2, which is weighted more heavily, also includes central line-associated bloodstream infections and C. diff. And fast susceptibility technology can help with respect to all of these issues. Next slide. The last penalty program is hospital readmission reduction. This is where you can get up to a 3% penalty on hospitals having excess readmissions above the national average for cardiac, pulmonary, orthopedic issues. But the issue here is you don't need to be readmitted for those issues. If you're readmitted for virtually anything, including any type of infection or even a hangnail, that's considered a readmission. And you can see that the average penalty in 2015 for readmissions was over $160,000. Next slide. The last factor, inpatient quality reporting, is actually where your hospital can get a benefit. So a 2% financial incentive based upon the quality of reporting, ostensibly so that consumers can make informed decisions based upon published infection data. This is the famous Hospital Compare website, and it does include things like C. diff and bloodstream infections. And while there's considerable disagreement about the value of these ratings and their validity, this is a factor that the public is going to use to make their decision with respect to whether to go to your hospital or the hospital down the road. So it's important that your scores better look good. And if you have higher rates of infection, you're going to appear to be a poor performer. Next slide. So when we look at the sum of all of these things based on the 2015 data, you look at all of the penalties and you see that the average penalty assessed against the hospital was almost $800,000, with the poorest performers over $8 million. This is a substantial amount of money which all hospitals need to be taking into consideration. And this is not the only way hospitals are penalized. You're also penalized under deductions from the Deficit Reduction Act, which stated that hospitals would no longer receive the differential or the enhanced payment when the sole reason for the differential was reasonably preventable by adherence to evidence-based guidelines. This is the whole presence on admission condition thing. So if you come into the hospital with A and you wind up with B, you're no longer going to be reimbursed for the differential between A and B. And if B is the infection that was reasonably preventable by adherence to evidence-based guidelines, you're going to be penalized under the Deficit Reduction Act in addition to the Affordable Care Act. Next slide. In addition to the penalties under the Affordable Care Act and the Deficit Reduction Act, these infections themselves are very costly to hospitals. They also increase the length of stay, which could have been used, obviously, for more profitable patient throughput. And you see the averages per infection there, including things like sepsis and C. diff. Next slide. And if we're following the money, we need to look no further than sepsis. Sepsis is the most expensive condition treated in hospitals today. $24 billion was spent on sepsis in 2013. That's more than 55 million every day. It's an astronomical number. Sepsis nearly doubles the cost of a hospital stay as opposed to other diagnoses. Patients are 2 to 3 times more likely to be readmitted for sepsis, again, getting penalized again under the readmission reduction scores. Sepsis nearly doubles the cost of a hospital stay, and it's the top cause of medical malpractice claims of hospital-admitted patients. So it's really hitting all of the markers that we talked about. Next slide. In addition to sepsis, C. diff is very costly. So this was a study that was done in Virginia showing the average hospital stay without C. diff to be a little more than $35,000 versus the average hospital stay with C. diff to be almost double that amount, or close to $70,000. And the average length of stay for a patient with C. diff was more than double those without C. diff. Next slide. In addition, patients with C. diff were more than 3 times as likely to die than those without C. diff, and were also more than twice as likely, again here, to be readmitted. So again, remember the penalties under the ACA, with both C. diff and sepsis ranking very high in that readmissions rate and penalty. Next slide. And here you can see from this chart the percentage rate of each infection with associated direct costs, length of stay, and mortality rates. And they're all, unfortunately, very significant. Next slide. In addition to the cost of the infection, the regulatory burdens, the liability potential, and the drugs themselves, and the liability potential, the drugs themselves are also really, really expensive. So why overuse them when they're not necessary and only create more harm, and can result in cost savings from $200,000 to $900,000 a year based on improved antibiotic stewardship. Next slide. So in summary, remember the legal issues. Was the HAI preventable? Was the HAI properly treated? Was the HAI treated promptly? Again, not so many legal issues here, but all of which potentially involve utilization of innovative technology like fast susceptibility technology. And then the question to ask is there available technology that will address these issues and result in improved patient outcomes with minimal risk, liability, cost, and training? Next slide. And remember my beautiful photo. So patients should not be deteriorating or dying waiting for culture results when the technology currently exists that provides a fast, accurate, low-cost solution which can result in the prevention of much avoidable and even deadly harm. Remember the MIC, the right drug, the right dosage, the right duration with the least collateral damage to the patient, which also improves outcomes, reduces costs, reduces antimicrobial resistance, and reduces liability. And if this were you, and this was me, wouldn't you want your hospital to quickly and accurately diagnose and treat your infection with minimal potential adverse impact in a cost-effective manner? Thank you very much.
Thank you for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We've got a few questions coming in, and it looks like this would be a good place to start. In your opinion, does fast susceptibility technology qualify as an emerging standard of care? If so, why?
Yes, it definitely meets the legal criteria established in the case law. Since many hospitals are using the product and publications have already documented the success of this technology. And kind of the legal standard of care with respect to technology is if it's reasonably reliable, readily available, won't harm the patient, and the clinicians are competent to use it, then it really should be used. And remember that facilities such as teaching hospitals can be held to a higher standard of care. And therefore, it's very important to stay even more attuned if you're in one of these type of facilities to the latest advancements in technology and innovation.
Thank you for shedding some light on that. We've got another question here. What do you feel are the best arguments to be made in getting this technology accepted by the Value Analysis Committee?
Well, the evidence clearly shows that 7 to 8 out of every 10 patients can have their therapy changed, which results, by using this technology, which results in a reduced ICU length of stay of 1 to 2 days. And depending upon what you're in the ICU for, those costs can range from $1,200 to even $19,000 a day for ICU days. And when you compare the cost of a $125 test to even a $2,500 ICU stay, I think that it becomes fairly apparent how to get this technology, how to get the attention of the Value Analysis Committee with this technology. And there are also decreased costs in the antibiotic stewardship program interventions and the decreased cost of antibiotic therapy, the lower drug costs, as well as the decreased risk of penalties and the enhanced potential incentives under the Affordable Care Act.
Great, thank you for that answer. We've got another question here. Since the Accelerate Pheno system allows for only one run per module, what factors should you consider for workflow and prioritization of analysis?
Well, from what I understand, the Pheno system throughput can actually handle the vast majority of any type of volume that most hospitals can generate, except for maybe the largest 100 or so centralized hospitals that have centralized labs. And if you do have an overflow, then I suggest you perform a risk analysis based on a stratification of clinically verified stratification of patient risk.
Great. And we have another question here. Is there a relatively simple ROI tool that is available for making the business case for rapid diagnostics?
That I think I might defer to Accelerate on to see if they have done that.
Yeah, so we actually...
Someone on the phone?
Yeah, so this is Levi Kerwin with Accelerate. We do actually have a very carefully modeled tool that allows you to take the current literature showing the time to result and how that impacts therapy interventions and patient care using an institution's own numbers for both rate of incidence as well as cost of care. And so we're happy to deploy that wherever anyone has a question about how this would look at their hospital.
Great, thank you for clearing that up. I have another question here. This audience member would like to know what specific fast culture and susceptibility technologies are being referred to.
Levi, do you want to take that one as well?
Yeah, that's good, Russ. So this technology is the Accelerate Pheno system is the analytical system, and the Accelerate Pheno Test Blood Culture Kit is the technology that underlies being able to test directly from a positive blood culture without going to solid media or isolate from subculture. So it's, again, as Russ covered it just briefly earlier in the presentation, there's additional information on our website that I'd be happy to share with this questioner and also with the rest of the audience one-on-one at our website at accelerate-diagnostics.com.
Great. And we have another question here, just for further clarification. What is the product name / manufacturer for this new AB susceptibility technology? How many hospitals in the nation have implemented it?
Yeah, so I'll take that again here. So Again, the name of the product, the name of the test system is the Accelerate Pheno System. The name of the consumable or the kit that's used for testing positive blood cultures, as indicated in the instructions for use, where sepsis is suspected, a bloodstream infection particularly. And so that test and that system are approved by the FDA and have been approved since February under a de novo marketing authorization. Since there's nothing like it, there's no actual predicate device because of the novelty and the power of how it works. The number of hospitals that are currently evaluating the system and or are clinically live is currently just under 100 institutions in the United States, as well as an additional 65, I think at last count, in Europe and the Middle East.
Great. Thanks for clearing that up. And I believe that's all the time we have for today. I want to thank Accelerate Diagnostics for the excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.